Good morning. Welcome to Providence Medford Grand Rounds for March. Today, we're pleased to have the Dr. Grant presenting on generalized peripheral neuropathy, and we're going to start with Dr. Peter Grant. Dr. Grant is a physical medicine and rehabilitation physician who's been in our valley a long time and has been joined by his sons, Austin and Colin. Dr. Grant graduated with honors from Texas Tech University Health Science School of Medicine and completed his internship and residency in physical medicine and rehabilitation at Ohio State University. He's also the past president of the American Association of Neuromuscular and Electrodiagnostic Medicine and past chairman of the American Board of Electrodiagnostic Medicine. Diplomat of the American Board of Electrodiagnostic Medicine and American Board of Physical Medicine and Rehab. And he has also served as a consultant to the FBI and OIG on electrodiagnostic testing fraud. And he continues as an assistant professor and adjunct at the Ohio State University. And we're pleased to have all of you this morning. Welcome, Dr. Grant.
Oh, thanks, Eric. I appreciate you asking myself and my sons to be a part of this program. I'm going to go ahead and get started then and move forward here. Today's presentation, I'm going to talk a little bit about the basics of generalized peripheral neuropathy, the types of things that you might look for in your history taking and your physical examination, and then talk about some of the subclasses and types and the causes of generalized neuropathy. I want to hit a lot of these things fairly quickly because some of this is going to be review. At that point, hopefully my son Colin will be on. We're having some tech issues. If not, I'll continue on with this portion, which basically is going to be talking about the electrodiagnostic evaluation of generalized neuropathy. It'll be in a case format at that point, so we'll present a case and show you some of the setup and how we do the testing. Talk a little bit at that point about hereditary neuropathy, especially Charcot-Marie tooth, and then present a second case, and then turn it over to my other son, Austin, who will present two cases that are pretty interesting and that will highlight a number of different things about generalized peripheral neuropathy. Some general things, the prevalence, it's pretty significant, the amount of generalized peripheral neuropathy that's out in the community. By midlife, which is like 40 years old, over 2% of population in the United States has this malady. And then by the time you're 55 or older, we're going to see 8% of the people have this. One point I wanted to make was that the history and the physical examination are really important. They'll get you there a lot of most of the time, but with electrodiagnostic testing added to that, you're in the 85 to 95% sensitivity range of picking up the electrodiagnostic or the generalized neuropathy, and also having better understanding of what type it is and therefore what might be causing it. You can subdivide generalized neuropathy into acquired neuropathies and hereditary neuropathies. The acquired neuropathies are the ones we tend to think of: toxic, general, or diabetic, thyroid, those things, and they far outweigh by number the hereditary neuropathies. Acquired neuropathies, this is sort of a list. I'm not going to go through all of that, but endocrinopathies like thyroid and systemic diseases, diabetes, nutritional deficiencies, toxic, a lot of toxic. When you think toxic, you can think of pharmaceuticals, you can think of environmental toxins, herbicides, pesticides, organic solvents, so there's a lot of different toxic neuropathies. In the hereditary group, probably the most common is CMT or Charcot-Marie tooth, both type 1 and type 2, and then some of the lesser common ones are listed there. With regards to history taking, you have to think in terms of the nerve types or different things in your history taking that will help you in the actual diagnosis part of things, right? Is this motor? Is it sensory? Is it both? Is it autonomic? What sort of symptoms do they describe? And then the type of involvement, is it protopathic or epicritic? We'll talk about that in a minute. It has to do with the different types of fibers that carry the different sensory impulses. And then is it distal versus proximal? Is it symmetric or is it asymmetric? I mean, the typical ones we see, the thyroid, the diabetes, the alcohol, they tend to be distal more than proximal, obviously. And then they tend to be fairly symmetric, though there are things that can cause them to be a bit asymmetric. Is it an acute or subacute process, or is this something very chronic, like a lot of them we see? And then, of course, we talked about, is it hereditary or acquired? When you're asking about sensory symptoms, these are usually going to be first before motor. Numbness and tingling beginning in the balls and toes and then slowly progressing up the legs. I usually tell my patients it may take a decade to get to your ankle, it may take a decade to get to your calf, another decade to get to your knees. Um, they can describe things like numbness, tingling, burning, aching, cramping, woody sensation. My legs feel dead. The idea of walking on a wadded up sock, I hear that's very commonly, or something is compressing my foot. Motor symptoms are usually later, and the first motor symptoms may be they speak about their balance is off, their gait's a little unstable, especially on uneven ground or stairs, and especially when it's dark or their eyes are closed, because we start to have compensatory input to help us with balance with vision. And so if you take that away, all of a sudden they don't have that proprioception and they have some sensory problems, which we'll talk about later, a sensory ataxia. We'll talk about what that is that comes along with the generalized neuropathy. In fact, I see their sensory ataxia. So I'll mention that real briefly. This is what I tell my patients when they come in and they have balance trouble, and it's due to the progression of their neuropathy affecting their sensory input. I tell the patients, when you're 20 years old, you would have a symphony of, sensory input that would come from your legs and feet and toes. The joints would be sending information about the angle they're at, the pressure that they feel, and all this information would just be very synchronous as it came up to the brain. But now we're having this neuropathy problem, and all of a sudden, some of the nerve impulses are getting there at the same speed as before. Some are slowed, and some are actually blocked. And so what the brain sees from that is it sees a dysynchronous input from the sensory modalities. And that is read by the brain as, this sort of imbalance problem, or it doesn't feel the ground well. And they talk about that being, that they don't have good balance. If the motor problem progresses, you can actually get foot drop, and then you start to see, frequent falls because of that. When the numbness and tingling and the other symptoms reach to the knees, that's about when you start to get it in the hands. We often get referred people that have numbness and tingling in the arms and hands as well as feet and toes, and often they will have carpal tunnel or some other problem predisposed because of their generalized peripheral neuropathy. But it isn't actually the neuropathy in the hands yet. That tends to be a little later. Um, as it progresses, you'll start to see atrophy of the foot intrinsics, and they get this toe clawing or hammer-toe deformities. In the hands, they can have atrophy, but again, that's going to be long-standing disease. And then, of course, autonomic involvement, changes in sweating, heat, cold, color changes, things like that can come along with this as well. Typically, you have that distal gradient, which is most common, meaning it starts in the feet and slowly moves up the legs. It usually is relatively symmetric. If they have an asymmetric presentation, often in the history, you can find that they've had some sort of injury, trauma, surgery on that side or in that leg, and that's why that one sort of came on a little sooner than the other. If it's grossly asymmetric, then we have to consider, is this something else? Is this a radiculopathy, plexopathy, some other peripheral nerve lesion and not the generalized peripheral neuropathy? Large fibers, when they are affected, you lose vibration, you lose light touch, proprioception. Smaller fibers, you lose pain, pinprick, cold. Basically, with most generalized neuropathies, you get a bit of both. It's a mixed batch. With autonomic involvement, I mentioned this before, you can get dystrophic nails, you can get sweating problems, you can get changes in color and temperature associated. And often the autonomic goes along with some of the other motor and sensory findings. Important to ask about other diseases, obviously. Do they have diabetes, alcohol? Is there any history of alcohol abuse, vitamin deficiencies, gastric bypass? Of course, you get nutritional problems associated with that. Is there any family history of generalized neuropathy? Or you can even ask, did anybody else in your family used to have feet like yours? If they have like atrophy in their feet, high arched feet, toe claw deformities, ask about that, because sometimes people live their whole life with that and they have a neuropathy, but they never have it diagnosed. Other exposures, I mentioned some before, but chemotherapy is really important. One of the things I always ask about. And then some other lesser common problems that can cause this are listed there. With regards to recreational drug use, nitrous oxide is huge. We gave a lecture at the Southern Oregon Medical Society a month or two ago on Whippet neuropathy and nitrous oxide neuropathy. And one of the cases we're going to present later in this talk is about that. It's a real problem in our valley, actually. And then exposure to industrial solvents, heavy metals, herbicides, pesticides, organocides, something to ask about. I've mentioned this before, two different types of pain. Protopathic pain is sort of poorly localized. It's very dull and aching, and it's mediated by large unmyelinated C fibers. Epicritic pain is more sharp and well localized, and they're smaller myelinated A delta fibers. Now, the nerve conductions mainly assess the large unmyelinated C fibers. So we don't have a real good way to look at the smaller fibers. So if a person comes in, typically it's mixed. So, we're going to pick up the component that we can pick up with the unmyelinated C fibers, the larger ones. But if you come in and it's more purely small myelinated A delta fibers, the nerve conductions that we do are not going to pick that up. Luckily, that doesn't happen very often. Most all the time, if they have a neuropathy, we're going to identify it. So again, by category, what our job is when we see a patient to help you all and to help your patients is we want to be able to identify that they have the problem, but then also give some critical information. Is it motor? Is it sensory? Is it both? Is it axonal or is it demyelinating? Um, and those are important things because then you start to be able to identify what category it might be in. As an example, here is a category of it's axonal and it's both motor and sensory. This is the largest category. This has diabetes, it has rheumatoid, it has alcohol, it has all the nutritional problems, all the pharmaceuticals, all the toxic stuff. That is in this category. Okay. And then here's some drugs. Just I'm going to throw them out there. I'm not going to read them off, but statins is one where we always think of statins in myopathy. Actually, statins more commonly cause generalized peripheral neuropathy than myopathy. So there's a lot of different drugs out there that we see our patients they're taking that can have the potential of causing a generalized peripheral neuropathic process. Axonal, where it's motor more than sensory. Lead is one you think of. Porphyria is another. Axonal Guillain-Barré, critical illness neuropathy. Axonal, where it's only sensory. These are getting down to the ones that are pretty uncommon. Some of the paraproteinemias, some drugs there, Crohn's disease. Now we're going to get to the demyelinating ones. The first ones we talked about, there were axonal. The demyelinating ones, motor greater than sensory. You have AIDP, CIDP, which is Guillain-Barré essentially. And then you've got hypothyroid, and you've got some other like arsenic and hereditary sensory neuropathies. Uniform demyelinating neuropathy. The first is segmental. This is uniform. These are really hardly ever see these, but I'm throwing them up there anyway. Couple of comments about the more common ones. Diabetes, it is the most common cause of generalized neuropathy, no doubt. 60% of patients with diabetes will at some point develop generalized neuropathy. One of the classic studies way back in 1973 said that 8% of the time that the diagnosis of diabetes is made, at that 8% of the time, they already have a generalized neuropathy. I can tell you that through the years, it's not common, but it's not uncommon that we diagnose the neuropathy, and that's the first time then the workup finds, oh yeah, this person does have diabetes. So sometimes it's the first indicator that they've got that problem. Alcohol abuse. 10 to 15% of alcoholics will get this. If they have a thiamine deficiency, it's mainly sensory and smaller fibers. More commonly, without the thiamine, yeah, it's a motor and sensory involvement. What's interesting is that these patients I have patients that tell me when I ask about alcohol, oh, no, I don't drink, doc. I used to drink pretty heavy way back when I was in the Navy, 40 years ago, 30 years ago. It sort of sets up the ticking time bomb. If they have a significant alcohol problem for a period of time, 5, 10 years, even if it's a long time ago, it sort of lies beneath the surface and then somehow comes up later. On physical examination of these patients, often reflexes are decreased. The most sensitive sensory indicator is vibratory loss, but using a 128. Remember, a vibratory can be 128, 256, 512. So make sure your tuning fork is 128. That's the lower one. And that's going to pick up sensory involvement of neuropathy. And that'll be your first physical examination finding. I test at the toe, at the ankle, and at the knee, and you'll just see it march right up over time. You can text some of these other modalities there as well. Motor testing, need to really be able to test the foot intrinsics and extensor hallucis longus, flexor hallucis longus well. Then you can also look, and later on, you get foot intrinsic atrophy and toe clawing deformities, some of the coordination and ataxia things we talked about, even some vascular changes that end up causing like a onychomycosis. Long-standing neuropathies, you're going to get high arch feet and toe clawing deformities, and the reflex loss is predictable. It starts distal, ankles, then knees, and then it's in the upper extremities, distal to proximal. One quick slide about screening. We do not do that in our office. We let the referring physicians do that. But this is sort of just a general outline of the things that can be very helpful in the first line of screening. I won't go over them, but as you see them, you can see which, that each one is pointed toward certain particular problems that you see, the thyroid, diabetes, and other problems of that type. And then treatment, just one quick slide about treatment. Nerve membrane stabilizing agents, Neurontin, Lyrica can be very effective, even at lower dosages. Duloxetine can be helpful. The local pharmacies, the compounding pharmacies have their own little secret potions that they make, and they often include some of the things that are listed there. Neurontin, ketamine, lidocaine, Elavil, and those can be helpful in a lot of people. If they need it and they have a significant progression of their problem, getting PT or OT involved for some of the things listed there, strengthening, gait training, fall management, and then treating the cause, of course. If we can identify that this is diabetes or thyroid or something like that, obviously treating the cause can be helpful. And then if they have the MTHFR gene mutation, giving L-methylfolate can be helpful in that as well. Here's where I was going to introduce my son, Colin, who I still think has not been able to join us. Very quickly, Colin grew up here in the Valley, went to St. Mary's, went to BYU, got his degree in Korean studies, then went to Tulane Medical School. And then after that, residency was at Ohio State, some 30 plus years after I was there. And then actually after his PM&R, he did a year fellowship in the anesthesia department at Ohio State, in pain. So he does a number of different injections, epidural steroid injections, radiofrequency ablations, things like that over at the surgical center. And so I'm going to, because of the tech problems, I'm going to go ahead and talk a little bit about what he was going to be presenting. So the electrodiagnostic evaluation, let's talk about a case, and we'll just weave that into it. Case number one, we have a 77-year-old right-handed male. Over the last couple of years, he's noted numbness, tingling, aching, cramping, mainly in the balls and toes, but to a lesser degree, the lower legs or ankle areas. Really no low back or hip pain or anything else that makes us think like of a radiculopathy or anything. His past medical history, really not so impressive, except possibly that hypothyroid for 10 years. No other toxic exposures or other causes. Family history was negative. On physical exam, a vibratory was absent at the toes and ankles and decreased at the knees. So we're starting to see some of the things that might be related to a generalized neuropathy. Light touch drop, pinprick dropped off in the feet and toes on both sides. He had very mild weakness in the foot intrinsics and DHL. Deep tendon reflexes were absent, knees and ankles. Moderately severe atrophy, and he was already getting some toe clawing deformity. I think you'll even see that in the pictures in a minute. And he had some moderate onychomycosis. Pulses were adequate. It didn't look like it was a vascular problem. So EMG testing, what we're going to do is we're going to look at bilateral legs. One leg wouldn't be enough because you can have a peripheral nerve lesion on one side. You want to make sure this is a generalized polyneuropathy, especially distal leg and foot muscles on the EMG testing. Now, remember in electrodiagnostic testing, there's two components. There's the EMG, which is the little pin stick, and basically we're able to identify denervation and then also what we call chronic motor unit abnormalities, and that tells us about how long this has been going on and how severely it's affecting in the body reacting to this. And then the nerve conduction studies, which is the little zings or shocks that we give to tell us how fast and how efficiently the nerves are conducting. So information from each of those tests is put together with the history and physical to come up with the diagnosis. So on the EMG, we especially look at distal leg and foot muscles, since that's where this is a beginning. Is there denervation? Are there some of these chronic neuropathic changes? And then what's the distribution of those abnormalities? This is sort of what the EMG looked like. And I'm going to show you, I'm going to bring in some colors here. There we go. So notice that the EMG changes are, by the way, I'm not going to get into the weeds on this, but the yellow ones there are actually the bottom two should have been yellow. That was my fault. That where it says 2 to 3 plus, that talks about the different types of denervation, and then over on the right, those categories deal with the chronic motor unit changes. And so you can see that it's worse in the foot, and then you come up into the posterior leg or calf, the gastroc and soleus, and it's a little less. And then you come up into the anterolateral leg, and it's a little bit less. So you can see this sort of is a graded thing, and as it progresses, it raises up higher. In other words, when I first see a patient with a milder problem, I might only see the changes in the feet, but in time, it starts to involve more and more proximally. The nerve conduction study, we're going to look at some motor nerves and some sensory nerves. We want to look at them again on both sides. Things like H reflex and F wave studies, don't have to understand what they are. Those are just some longer loop studies, but they can also be helpful in identifying this problem. And then if you see slowing, that usually indicates demyelination. And if you see loss of the size, the amplitude of these waveforms, the sensory and motor waveforms, that usually speaks for an axonal lesion. So here's the first thing we're going to show you. This is a superficial perineal or superficial fibular nerve setup. We're going to stimulate right up there where I'm holding that stimulator. And then 10 centimeters distal to that is where we have the electrodes, the black and the red ones there, where we're picking up the nerve conduction as it goes down. You can also see the toe clawing deformities in this patient and the onychomycosis involving his nails. And then what happens when we get this is we get some waveforms. Now, right there where it says 1, 2, 3, and it says 6.6, and the lower one says 6.5, this is right on the top and left on the bottom. Those waveforms should be 5 or 6 microvolt in size or bigger. And over the right there in the green, the top one was 2.0 microvolt. So it's only a third of the very lowest that it should be. And then the bottom one was even worse. It was 1.1. So very small sensory responses are seen with that study. Now, the next study we do is a motor study. It's the fibular motor study. We're picking up that little black electrode is over the extensor digitorum brevis, the EDB in the foot. And what we get with that is, again, little waveforms that are, the green tells us it's 1.8, 1.8. Now, these are stimulated. The top one is at the ankle. The middle one is below the knee, and the other one is above the knee. These should be 6, 8, 10 millivolts in amplitude, and they're down at 1.8 and 1.5. So again, motor responses now are very small. Another motor would be doing the tibial motor. I'm not going to belabor this, but you can again see how small those are, 1.7 and 0.6. Top is at the ankle. The bottom one is up in the popliteal fossa where it's stimulated. We can also do what's called an H reflex study. And the H reflex is there on the right. You see all those things on the right where that line is? On this one, which is this patient, they're completely absent. Top to bottom, I'm increasing the stimulation, and that's why you just start to see these, what are called M waves, getting a little bit bigger on the left. But never did we see the H reflex on that one. And this is what the report would say in that case. You can see under diagnostic impressions, generalized peripheral neuropathy, severe and chronic, involves motor and sensory. It's axonal. And then the etiology was consistent with his long-standing thyroid dysfunction. With regards to hereditary neuropathies, very quickly, Charcot-Marie tooth disease is the most common, even though it's not very common. And it has a number of different subtypes. With this, we see, because it's demyelinating, we see very slow nerve conductions. I mean, nerve conductions should be 50, 60 meters per second. Sometimes we see them 20 meters per second and lower. There's also you see weakness and atrophy, high arched feet. And when you've got widespread changes in the hands and feet, and a lot of denervation going on with that. Charcot-Marie tooth type 2 is going to be axonal form. It often presents clinically to be pretty much the same. So case number 2, very quickly, we have had a recent upsurge in cases of this in the Rogue Valley. We've seen about 8 cases in the last 6 months here in our office, all these patients are in their 20s or 30s. So they're very young and they have really nothing else going on. That's the thing that's most impressive. They're very healthy people. And then here we go. So 30-year-old male, presented with symmetric upper and lower extremity problems. He was otherwise healthy, numbness and tingling in the arms and hands, all the way up to the mid-brachium, just below the shoulder. And the legs and feet all the way up to the mid-thighs. I mean, what's impressive is this patient is looking like a diabetic neuropathy of about 40 or 50 years duration. And yet it's a young and otherwise healthy patient. Aching and cramping, weakness in the legs and feet. This person even had a foot drop bilaterally and was falling because of it. So something wrong, big time wrong is going on. The patient didn't mention nitrous oxide, but when asked, talked about using it for a significant period of time, though he wasn't using it currently when I was seeing him, but he had used it from June through 24 through March of 25. And he was using a lot. This 260 gram canisters, which is a huge amount, he was doing 2 or 3 of those in a day. So in the lower extremities on his physical examination, fairly classic. He had absent vibratory perception. Pinprick was densely decreased below the knees. His gait had a steppage quality and ride base because of his foot drops. A lot of weakness going on, but it had only been a shorter period of time, so he didn't have atrophy yet. In the upper extremities, again, there were signs of a generalized neuropathy that looked like of a very long duration. We talked about before the size of these things. I mean, his perineal motor was 0.2. Again, that should be bigger than 8. So that's like a 40-fold difference, right? It's about a 40th of what it should be. Same thing with tibial and the sensories. Sensories had no responses at all. So again, this is shaping up to be really severe neuropathy in a young individual. And so, he was diagnosed with very severe and chronic motor and sensory axonal, consistent with his nitrous oxide use. Um, where do these people buy this nitrous oxide? Or it's called whippets, by the way, because they do use these nitrous oxide canisters in restaurants, right? Where they put them in those things and you make whipped cream out of it. But that's why it's called whippets. But believe it or not, you can get these a lot of places, and they're legal, totally legal to buy these. In fact, if you look there, you can tell by the font that this is Amazon. And you can get these small little 8-gram canisters, but you can also get the 640, which are huge. I mean, and even bigger, 2,100 grams. And so it makes it way too easy for people to get this and abuse this. Now, the pathophysiology, very briefly, is that when you use nitrous oxide, it inactivates your B12. The B12 that you look at on your testing may look actually normal, because it's not that you don't have B12, it's that the B12 you have is inactive. It's inactivated by the nitrous oxide. So MMA, or methylmalonic acid, is probably the best way to look for this problem. So quickly, I'm going to introduce my son, Austin. Austin also graduated from St. Mary's here in town and then went on to BYU and did his undergraduate training. And then from there went to Tulane Medical School. And then Ohio State. All 3 of us did our PM&R training at Ohio State. Austin joined the practice 3 or 4 years ago. And he's going to continue on with a couple of other case presentations that illustrate a number of other factors about the generalized peripheral neuropathy.
Morning, all. So case 3 here, 53-year-old female referred for EMG of her bilateral lower extremity symptoms. She had had symptoms slowly, progressively over 4 to 5 years. Numbness, tingling, pins and needles in the soles of her feet, more than her whole foot. She also noticed this was sort of worse in bed and worse with her legs up. She had some aching and cramping in her legs and feet and toes bilaterally. She did deny weakness, denied any bowel or bladder changes. She also noted some occasional numbness and tingling sensations in her hands and feet bilaterally. So, a quick physical exam. She's a thin framed, small, physically fit female. Her gait was normal. She had some decreased vibratory sensation in the feet and toes bilaterally. And as we spoke of, that's one of the earliest findings. Light touch, pinprick was decreased in the balls of her feet and her toes bilaterally, deep tender reflexes, 1+ in the knees, and yet absent at the ankles. Strength testing, 5- out of 5, so just slightly weaker than normal in foot intrinsics bilaterally. And she did have some significant toe clawing deformities, again bilaterally. Upper extremity mano-motor testing was normal, except 4- out of 5 with wrist extensors and finger extensors bilaterally. Now that's kind of an odd pick out there, but obviously a little foreshadowing. It's going to come up a little bit later. So our superficial fibular study at the ankle mildly decreased sensory nerve action potential amplitudes. Our motor study, again on the screen, the top 3 are the fibular motor studies, and the bottom 2 will be the tibial. And these are slightly smaller than I would expect for someone of her age. The green, we have the speed of 41 meters per second and 42 meters per second, not terribly slowed for the lower extremity. So I'm thinking this is probably more axonal. H reflex is delayed significantly. Again, there's a way that we calculate based off of the leg length of the patient and the age of the patient, as stated before. And the calculated is 28, and hers was actually at about 33. So this is our needle EMG slide here. And as you can see, some occasional signs of denervation. That's the spontaneous category there. In foot intrinsics, and slightly decreased motor unit action potential, recruitment, and amplitudes. So what is going to be our diagnosis here? Generalized peripheral neuropathy. How are we going to describe it? Anything about the history that we saw? Did we take a toxic history? And again, we'll talk about that all here in a second. Motor greater than sensory. The motor study was significantly lower. The waveforms were lower than were the sensory. That's why we say motor greater than sensory. Axonal, again, not a lot of slowing, but there was definitely axon loss with decreased amplitudes. And on physical exam, we also noticed that the wrist extensors and finger extensors were weak. So this is actually a case of lead toxicity. Thankfully, she had a diagnosis of lead toxicity about 3 to 4 years before this. So some of the workup we didn't have to do. We kind of, this fit the picture very nicely. Cause of this, why was this person have significant lead toxicity? We never found a specific cause. Some of the more common ones are well water, soil samples, and then the other investigations we look for are negative. You lived in New Orleans for 4 years, and the paint in some of these old, beautiful Victorian homes in New Orleans had a lot of lead in it back in the day, and so a lot of kids in New Orleans had lead issues growing up. That's something they always look for because kids are eating anything on the ground and walls, and that's where the paint is. Her highest lead level was 30 micrograms per deciliter, and now her lead level had dropped down significantly, but that's still quite a lot of lead. In general, lead toxicity, 0 to 10 micrograms per deciliter is fairly normal, a lot less in kids. 10 to 40 is when we're starting to think that this is more regular exposure. For kids, we're going to treat with symptoms between 5 and 40. Greater than 40 is very serious and needs treatment. Greater than 80, we're in big, big trouble. So this was, sort of one of the paragraphs that we'd have in our report. We don't need to go through it too much. It just sort of summarizes all the things we just talked about. And as far as diagnostic impressions, we'd say generalized peripheral neuropathy, moderate and chronic, motor greater than sensory, axonal, etiology consistent with lead toxicity. Another case here, I think this is our last case number 4, 45-year-old right-handed male referred for left shoulder and upper extremity symptoms. Began with a motor vehicle accident about 2 years ago. He had pain in his left shoulder with shoulder abduction and shoulder flexion. Deep aching pain in his shoulder, especially at night. Radiates to the brachium. Some pain and tightness in the neck and parascapular area. Denies numbness, tingling in his arm. Denies weakness except from physical exam. Short, physically fit male. Severe hand intrinsic weakness. The FDI was much worse than the thenar side. So the ulnar innervated seems to be worse than median innervated. Severe toe clawing deformities and a saber shin deformity bilaterally, which just speaks to significant atrophy of the muscles in and around the tibia. Had a positive Tinel's bilaterally at his wrists and his elbows. Notably, there was decreased sensation in his hands bilaterally. Manual muscle testing did show some significant shoulder abduction, some pain-limited shoulder abduction weakness, and significant hand intrinsic atrophy. More the ulnar innervated hand intrinsics than the median innervated APB. Deep tendon reflexes are absent at the biceps and the triceps, so we even have absent reflexes in his upper extremities. So there's a picture of his feet, massive, toe clawing deformities, as well as significant high arched feet due to foot intrinsic atrophy. And if we look at his hands, we can see on the left, there's a massive, what I would essentially just call a crater in his hand, in between the thumb and index finger. And then when we turn his hand over, we do see flattening of the thenar eminence. Again, that's more median innervated hand intrinsics, but it's across the board. So this is in the upper limb, and these are our sensory nerve studies to the thumb. So we test the median to the thumb and then the radial nerve to the thumb, again, sensories. Then we do the median to the ring finger and the ulnar nerve to the ring finger. And as you can see, these amplitudes are drastically small. In somebody that is healthy enough, his age, these should probably be closer to between 8 and 12. So, I mean, we're looking on an order of maybe a tenth of what they really should be. And then we were doing his motor study, this is his sensory study of his right upper limb. There was nothing, excuse me. So his first one was his left, second one was his right, and we just really couldn't get anything. Motor study here, again, significantly low amplitudes, but note the speed of all of these in the upper extremities. Normal conduction velocities in the upper extremities should be around 50. Sometimes in the 40s, sometimes you get some fast conductors in the 60s, but around the 50s is what we like to see. And this is less than half of that. So his median motor study is at 23 meters per second, and the ulnar in both segments, the lower segment and the upper segment, are in the 20s as well. Looking at his needle EMG is very, very interesting. So he had significant amounts of denervation in the hand intrinsic musculature, especially in FDI and the adductor pollicis brevis as well. Also of note here, in his lower extremities, you can see pretty much everything below the knee has 3 to 4 plus signs of denervation, which is almost as bad as it gets, with massively decreased, we say severely decreased here, massively decreased motor unit contraction. So there's very little sort of functioning muscle tissue in his legs and feet, with a lot of freely fibrillating muscle due to chronic nerve damage. So what is the diagnosis? Charcot-Marie tooth, type 2. Again, this is the axonal form. We used to call it hereditary motor sensory neuropathy type 2. Either one is perfectly fine. But again, Charcot-Marie tooth disease. So We are PM&R doctors by trade, and so we can't help ourselves here, but also point out some other very important findings. And again, when in our reports, this person was sent over for all these symptoms, and we diagnosed most of those symptoms, but there's a lot of other very interesting things that are affecting this patient on a day-to-day basis that we want to make sure that we can treat as well, and help you all see these things and send out referrals as needed, or get people in physical therapy, et cetera. So the patient also did have clear, severe bilateral carpal tunnel syndromes, as well as severe and chronic bilateral ulnar neuropathies at the elbow. Also of note, if we go back, the patient was also complaining of significant shoulder pain, and we felt like that was related to left rotator cuff dysfunction. Also of note, again, all these symptoms seem to start around 2 years ago with a motor vehicle accident. A lot of times a whiplash injury or other trauma can start a spiral of muscle tightness and disease that can eventually progress into a chronic myofascial pain syndrome. So in our EMG report, we would say, again, diagnostic impressions, very severe and very chronic sentinel neuropathy affecting all distal segments of lower, greater than upper extremity nerves bilaterally. And again, this would be related to, this is consistent with a very severe and chronic generalized peripheral neuropathy, or possibly a severe Charcot-Marie tooth disease. For the definitive diagnosis of Charcot-Marie tooth, the patient would need to be sent on to genetics. However, with this specific case, we could feel pretty confident with the amount of slowing there that this is probably what happened. And then we would list off the other 6 or 7 diagnoses that we would have in there, in the carpal tunnel syndromes, as well as ulnar neuropathies. And then again, in our reports, we try to do our best to make sure we mention the things that we did rule out as well, including there were no cervical radiculopathies, brachioplex, radial neuropathies, or lumbosacral radiculopathies. All right, that is it. We have a few moments. If anybody has, I don't know if we do questions or not, but we appreciate you guys letting us come and speak to you guys today. We are so grateful for your guys' support in the past and going forward. We hope that we can really just be a tool in your hands to help our patients here in Southern Oregon. Any other thoughts?
Yeah, I just want to sit down. I'm going to jump back in here also and just mention on this slide, we've got our contact information. We welcome if you have patients that you have questions about, maybe is this something we can refer, will the grants be able to help me with this? We welcome your call. Also, if you have somebody that is a bit urgent, we have 3 of us here in the office. So, if it's something that needs to be seen sooner versus later, let us know, give us a call. And so we'd love to talk about any of the patients. We are here to try to help you and your patients. So, what I'd like to do at this time is, Eric, if we've got any questions, we're really happy to answer any questions about what we've been talking about, or anything in general. I mean, we're talking about generalized neuropathy today, but when you talk about electrodiagnostic testing, we see everything from, the typical carpal tunnel and ulnar neuropathy and radiculopathy stuff, all the way to the, muscular dystrophy and ALS, unfortunately, and those things too. So we're happy to entertain any questions, but especially about the generalized neuropathy that we've talked about this morning.
Great. Just a couple of questions right now, and if anyone in the audience has any questions, please type them into the Q&A chat. I think one of the things primary care folks struggle with neuropathy is the causes of toxic neuropathies, when to test for those things. Is testing helpful, say like for heavy metals? When do you suspect those? That's one I always struggle with also. It's in the back of your mind, but it's not something like we see with any regularity. And then I guess the pesticides would be more typically an occupational exposure. Any thoughts on that?
Sure. first off, I think that, the history and the physical are very helpful, but they may not forward much information there, or they might not know. And so the electrodiagnostic testing becomes really important because on physical exam, a lot of these patients, no matter what the cause, are going to have some of the things we talked about: loss of reflexes, loss of vibratory perception, weakness, those things, right? So that doesn't help differentiate if this is axonal or demyelinating or motor and sensory. And those are the things we need to understand if we're going to talk about actual causation, those different categories that I put up there. So if for your example of heavy metal, um, our electrodiagnostic evaluation would put it in the category of motor and sensory and axonal. And at that point, that would be one of the things. There are the common ones that you look for. And then if they're still negative, then at that point you say, okay, what's the next? And 24-hour urine screen for heavy metals is going to be in that next category. So I think that it's sort of a stepwise progression of your diagnostic intervention, starting with the history and physical, then having the electrodiagnostic testing, which helps categorize it, then doing the simpler tests or the ones that find the most common causes. And if nothing's coming up at that point, then you can move on to the things that are a little more unlikely, but that need different testing, like that 24-hour urine for heavy metals.
Great. And I think we've in the past used the term idiopathic peripheral neuropathy a lot when we can't find a cause. Should we be using that, or is there usually a cause if we just look hard enough?
Well, I'm going to tell you that what I tell my patients is about a third of the time we never end up knowing the cause, and I still think that's a fairly factual assessment. Even with all the great testing that we have, about a third of the time, it all comes up negative. Now, the nice thing is the treatments that we offer. Remember the treatment slide? We have the nerve membrane stabilizing agents like Lyrica and Neurontin. We've got some of the duloxetine, some of the other things. The treatments that we have are usually going to help, and even if we don't know the cause, right? I mean, whether it's diabetes or thyroid or we don't know, that's where I would always start, is one of the nerve membrane stabilizing agents first. And usually they're going to find some element of benefit. What's interesting is sometimes they will say, "Oh, doc, I took it. And yeah, it was helping, but it made me really groggy." Or a couple of things I tell them is, number one is take it just at night at first, and let's see how that does. If you're a little groggy, no big deal. The other thing that I find is that the patients often will have benefit, and the untoward side effect within a week or two will diminish or go away, but the benefit stays. And so often I have them try to just persevere a little. I mean, if they're stumbling around and it's a horrible problem, that's one thing. But if they're just a little groggy or feeling a little thick or lethargic or whatever, have them try to push through a little bit with that, because often, like I say, at a week or two, that tends to dissipate, but the benefit as far as taking care of the numbness, tingling, burning, aching, cramping symptoms tends to stay.
Right. Here we have another question from one of our local docs. If I refer for nerve conduction testing and EMG is indicated, do you also perform that even if I did not specifically request in a referral? Is there a broader term that encompasses both nerve conduction and EMG?
We'll let Austin answer that.
Yeah. So for us, the nerve conductions and EMGs are just two parts of the same test. And I don't think that we've ever had any trouble with insurance when a referring physician sends over, a referring provider sends over nerve conductions only, and we do nerve conductions and EMGs, or they send over EMG and we do nerve conductions. For us, they go together. So we're always going to do both of them, always.
Yeah.
Right.
Now I'll emphasize that there's different information that we get from each. And so that becomes both of those types of information are needed to make the diagnosis. There's very rare instances where you might get away with just a couple nerve conductions, but for the most part, just like Austin said, we do both all the time. There isn't the term electrodiagnostic studies encompasses both EMG and nerve conduction. So if you want, you can just say refer for EDX, to grants. We tend to do what we feel is best for the patient. If we ever do something that you feel we're overstepping our boundaries, please let us know. But in general, for example, somebody comes in and they've been referred for lower extremities and they've got definite symptoms there and they need studies there. But as we're talking to them, they're talking about numbness and tingling in their hands and weakness and dropping things. We find it's better to just go ahead and do the test while they're here. It's cheaper for them. It's more convenient. It gives you guys more information instead of having to turn around, send them back later. So again, if anybody ever doesn't like the way that we do that, let us know. But typically, we find that gives the patient gives you all more information about what's going on, and it's more helpful to the patient. Provides a better quality of care to just get it done all at once.
Great. And for referrals, what's the just for a routine, what's the typical length of time it takes to get into your office?
Well, since there's not as much of us doing EDX in the Valley right now as there was maybe 6 months ago or a year ago. Um, I'm going to say that it's probably more like about 2 months. Now, like I said before, if you guys, if anybody has any patient that is more urgent, sometimes patients even come, our referral, we all know our catchment area is bigger. And so sometimes people come in from Lakeview and they're being, if it's a problem that you don't want to have them drive all the way back and then drive all the way out here 2 months later or whatever, let us know. Give us a call. We're happy to talk to you. And if it seems like it really is something that we need to see sooner, they'll stay overnight in a hotel and we'll find a way to work them in the next day or in 2 days. Because we do have 3 docs here. Somebody can see them at lunch. Somebody can see them after work. So we really think that yes, it's 2 months for the standard patient, but if we need to, we can definitely manipulate that time frame based on the needs of the patient, and we're happy to do that.
We also have a very robust cancellation list, and so I'll see, probably number of times per week. I'll look at the referral and I'll say, "Oh my gosh, this referral came from last week." So if you put either call us or put urgent on the referral and call us or text us, we can get people in sooner than that if needed. Just doing your best to communicate with us, what you guys feel like is important.
All right. We'll give it another minute, see if we have any other questions, but a big takeaway for me is the 128 hertz tuning fork.
There you go.
Yeah.
Yeah, that's actually a PM&R board question. What's the most sensitive indicator on physical examination of generalized neuropathy? And a lot of people answer reflex loss, which for years was thought to be the one. And it is very sensitive and it's very helpful. But the best answer is 128 tuning fork. And on that same question, it had 256. So you couldn't just know it was vibratory. You had to know that it was 128 vibratory.
All right.
And also when we do that vibration testing, it's important to test can they feel it or not. But we even take it a step further, and you can too, because sometimes people will be able to feel it, but within seconds, I'll ask them, I'll say, well, let me know when you can't feel it anymore. And within seconds, they'll say it's gone, and that thing's still buzzing like crazy in your hand. And then you can even show the patient, I'll put it on their finger and say, can you still feel this? Because I didn't restart it. And they'll say, oh my gosh, what is going on? So that's another way to be even more sensitive with your vibratory testing is maybe pick up a little bit when it drops off, when they can't feel it anymore, if they can feel it in their toes.
Good. Well, I'm not seeing any other questions. So thank you, Drs. Grant. We're sorry Colin couldn't join us, but maybe we'll have him back at another time in the future.
Yeah,
And
sure.
a really excellent talk, lots of great information. So thank you.
Well, we're happy to be here and we're happy to help out. If we have any other things you want us to talk about, we can do that. and appreciate it, and hope everybody has a great day.
Thanks. You too.